Good night. I am Sharon Strawn.
And I'm Shannon Johnson.
Our topic for the theory research paper is evidence-based practices in fluid and electrolyte management,
Which will be a review of the common electrolyte imbalances, nursing interventions, case studies, and patient education.
Enjoy.
Evidence-based practices in fluid and electrolyte management. A review of common electrolyte imbalances, nursing interventions, case studies, and patient education. Presentation objectives. Identify the role of electrolytes in maintaining body homeostasis. Identify common electrolyte imbalances and their causes. Recognize clinical signs and symptoms. Review evidence based nursing interventions and replacement therapies. Examine case studies with outcomes. Emphasize patient education in preventing and managing imbalances. Role of electrolytes in homeostasis. Regulate fluid distribution, maintain acid base balance, support neuromuscular conduction, facilitate cardiac electrical activity. It's essential for the enzyme function and cellular metabolism, controls the kidneys and the endocrine system. Overview of major electrolytes. Sodium, Na+, responsible for fluid balance and nerve transmission. Potassium, K+, responsible for cardiac rhythm and muscular contraction. Calcium, Ca2+, responsible for bone health, clotting, and nerve conduction. Magnesium, Mg2+, responsible for enzyme activity and neuromuscular function. Chloride and phosphate, responsible for acid base balance and ATP formation. Types of sodium imbalances. Hyponatremia. Hyponatremia is a medical condition characterized by a low level of sodium in the blood, defined as serum sodium concentration below 135 MEqL. It occurs when the amount of water in the body becomes too high for the amount of sodium, causing cells to swell, which can range from mild to life threatening. Symptoms vary but can include nausea, headache, confusion, fatigue, muscle cramps. Hyponatremia is caused by excess water intake, syndrome of inappropriate antidiuretic hormone secretion, heart failure, cirrhosis, diuretics, and its risks include cerebral edema and brain herniation. Evidence based management of hyponatremia. Monitor serum sodium every 2 to 4 hours. Maintain strict record of intake and output while on fluid restriction. Medications like Vaptans may be used for chronic conditions when fluid restriction is ineffective. Hypertonic saline 3% for severe symptomatic hyponatremia should be administered. Seizure precautions should be implemented. Identify underlying causes such as medications the patient may be taking. Hypernatremia. Hypernatremia is a medical condition characterized by a serum sodium concentration of more than 145 MEq per L, indicating that there is too little water for the amount of sodium in the blood. It typically results from a deficient of total body water relative to sodium, often due to dehydration from not drinking enough fluids or excessive water loss through sweating, vomiting, diarrhea, diabetes insipidus, fever, and burns. This imbalance can cause symptoms like tachycardia, restlessness, excessive thirst, confusion, and muscle twitching, and in severe cases, seizures or coma. Its risks include brain shrinkage and intracranial hemorrhage. Evidence based management of hypernatremia. Determining the root cause, i.e., inadequate water intake, diabetes insipidus, gastrointestinal loss, etc. Administration of 0.9% sodium chloride solution to stabilize the patient's circulation prior to addressing the sodium imbalance. Rehydrate the patient orally if possible, and evaluate renal function and medications. Types of potassium imbalances. Hypokalemia. Hypokalemia is a condition characterized by abnormally low levels of potassium in the blood. Potassium is an essential electrolyte for nerve and muscle function, particularly the heart, and is also crucial for maintaining fluid balance. Symptoms can include muscle weakness, flattened T waves, cramps, or abnormal heart rhythms, but sometimes there are no symptoms at all. Hyperkalemia is caused by diuretics, vomiting, NG suction, and alkalosis. Risks and complications are respiratory failure and cardiac arrest. Evidence based management of hypokalemia. Administration of oral potassium supplements for mild to moderate cases. Administration of potassium chloride intravenously. Potassium chloride should never be administered through IV push, as rapid administration of potassium into bloodstream can cause fatal cardiac arrhythmias and lead to cardiac arrest. It should be administered at a slow infusion instead. Continuous ECG monitoring and evaluation of magnesium levels as magnesium deficiency worsens with hypokalemia. Hyperkalemia. Hyperkalemia is a medical condition where there is an abnormally high level of potassium in the blood, typically over 5.0 to 5.5 MEQL. This can be dangerous as associated risks are cardiac arrest, ventricular fibrillation, muscle weakness, or paralysis. Causes include poor kidney function, hemolysis, certain medications, and a diet high in potassium. While symptoms often do not appear until the condition is severe, they include peak T waves, muscle weakness, and paresthesias. Evidence based management of hyperkalemia. Cardiac stabilization using calcium gluconate, shift potassium intercellularly using insulin and dextrose and sodium bicarbonate, remove potassium with sodium polystyrene or dialysis, as well as continuous ECG monitoring.
Types of magnesium imbalances. Hypomagnesemia. Hypomagnesemia is a medical condition characterized by an abnormally low level of magnesium in the blood, which can affect many bodily functions. It is often caused by alcoholism, malnutrition, poor intake, increased losses from the body, such as from diarrhea or diuretic use, or absorption issues. Symptoms can include tetany, seizures, muscle weaknesses, tremors, and confusion. The risks associated with hypomagnesemia include refractory hypokalemia, hypocalcemia, irregular heart rhythms, and seizures. Evidence-based management. Hypomagnesemia. Identify and treat the underlying cause. Hypomagnesemia often stems from conditions like chronic diarrhea, alcohol use disorder, or medications like diuretics, proton pump inhibitors, and chemotherapy. Correct other electrolyte imbalances. Hypomagnesemia is often associated with hypokalemia and hypocalcemia. These conditions often do not resolve until the magnesium deficiency has been corrected. Assess renal function. Caution must be used when administering magnesium to patients with impaired kidney function, as they are at risk for hypermagnesemia. Doses should be reduced by 50% and levels monitored closely. Hypermagnesemia. Hypermagnesemia is a condition where there is an abnormally high level of magnesium in the blood, most often caused by renal failure or excessive intake of magnesium through supplements, antacids, laxative, or IV magnesium therapy. Symptoms can include muscle weakness, bradycardia, hypotension, confusion, and depressed reflexes. The risk associated with hypermagnesemia is respiratory or cardiac arrest. Treatment involves addressing the underlying cause, often with IV calcium and furosemide, and in severe cases, hemodialysis. Evidence-based management, hypermagnesemia. Continuous monitoring. Close monitoring of vital signs, blood pressure, ECG, and neuromuscular function is essential in severe cases. Preventative education. Pharmacists and clinicians should educate at-risk patients, especially those with chronic kidney disease, to avoid over-the-counter magnesium products. Regular assessment. Periodically monitoring serum magnesium levels in high-risk patients to facilitate early diagnosis and intervention. Types of calcium imbalances. Hypocalcemia. Hypocalcemia is a condition where the calcium level in the blood is too low, below 8.8 mg/dl. Hypocalcemia is caused by post-thyroidectomy, hypoparathyroidism, and/or vitamin D deficiency. Symptoms include tetany, Charot's sign, Chavock's sign, numbness, laryngospasm, and seizures. Risks associated with hypocalcemia are life-threatening airway obstruction and arrhythmias. Evidence-based management, hypocalcemia. IV calcium gluconate for severe symptoms, oral calcium plus vitamin D for maintenance, continuous cardiac monitoring, evaluate magnesium levels, post-thyroidectomy, scheduled calcium protocol. Hypercalcemia. Hypercalcemia is a high calcium level in the blood serum. Blood calcium levels exceeding 2.6 mmol/L is defined as hypercalcemia. Those with a mild calcium increase that has developed slowly typically has no symptoms. Causes of hypercalcemia are malignancy or cancer, hyperparathyroidism, and immobility. Symptoms of hypercalcemia are nausea, vomiting, constipation, abdominal pain, loss of appetite, increased thirst, frequent urination, fatigue, muscle weakness, lethargy, confusion, memory loss, depression, bone pain, bone fragility due to the body drawing calcium from them, and irregular heartbeat. The risks associated with hypocalcemia are kidney stones and cardiac dysrhythmias. Evidence-based management, hypercalcemia. IV hydration with normal saline, calcitonin, bisphosphonates, loop diuretics, avoid thiazides, monitor ECG and renal function. Case studies. The following 3 slides will present case studies of patients presenting with the electrolyte imbalances, hyponatremia, hyperkalemia, and hypocalcemia. The symptoms, interventions, and outcomes of said interventions will be presented. Case Study 1. Electrolyte imbalance, acute symptomatic hyponatremia. Scenario: a 67-year-old female with phenomia presents with confusion and seizures. Her serum sodium level is 118 MEq/L. Interventions: rapid intermittent bolus of 3% saline was administered with careful monitoring every 2 hours. Outcome: sodium improved to 124 MEq/L over 24 hours with resolution of seizures and improved mentation. Case Study 2. Electrolyte imbalance, hyperkalemia in renal failure. Scenario: a 54-year-old male with stage 4 chronic kidney disease has potassium of 6.8 MEq/L, peaked T waves, and muscle weakness. Interventions: IV calcium gluconate was given, followed by insulin and glucose. Sodium polycystyrene was administered and he underwent emergent dialysis. Outcome: patient's potassium was normalized and his ECG changes were resolved. Case Study 3. Electrolyte imbalance, hypocalcemia after thyroidectomy. Scenario: a 52-year-old patient develops tingling in fingers and facial twitching 24 hours post-thyroidectomy. Labs show calcium 2 plus 7.1 mg/dl. Interventions: IV calcium gluconate was given, followed by insulin and glucose. Sodium polycystyrene was administered and he underwent emergent dialysis. Outcome: patient's potassium was normalized and his ECG levels were resolved. The role of patient education in the prevention and management of electrolyte imbalances. Patient education is a cornerstone in preventing and managing electrolyte imbalances, especially in chronic disease management. Teaching patients about medication side effects, dietary considerations, hydration, and early symptom recognition empowers them to participate actively in their care. Nurses play an essential role in teaching patients to monitor daily weight and recognize signs of fluid overload or dehydration, understand medication risk like diuretics causing hypokalemia, ACE inhibitors raising potassium levels, follow dietary modifications such as low potassium diets in chronic kidney disease or increased calcium or vitamin D deficiency. Practice safe fluid management like fluid restriction in SIADH. Recognize warning symptoms such as muscle weakness, confusion, palpitation, numbness, or seizures. Patient education improves adherence, reduces hospital readmissions, and empowers patients in self-management. In conclusion, electrolyte imbalances pose serious risk, including cardiac arrhythmias, seizures, neuromuscular instability, and life-threatening complications. Evidence-based nursing interventions such as lab monitoring, controlled replacement therapies, ECG surveillance, and cause-focused management are essential for safe care. Calcium, sodium, potassium, and magnesium disturbances each present unique challenges requiring vigilant assessment. Case studies demonstrate that outcomes improve significantly with prompt guideline-driven actions. Finally, patient education remains vital in preventing reoccurrences and supporting homeostasis across the lifespan.